Jenny.
How you can all hear me.
Yes.
Welcome to Meso Hour. My name's Jennifer Coles. For those of you that don't know me, I'm one of the clinical nurse consultants here at ADRI. And today I'll be coordinating today's session for Meso Hour. So just a little bit of housekeeping to start off with. We'll just be keeping everybody on mute for the first part of the session. And there will be plenty of time for questions and answers at the end of the session. Everybody can keep their cameras on if they wish, or if they're more comfortable with turning them off, that's also fine. And today's session will be recorded. So and we'll be putting that on our website by tomorrow, so you'll be able to see us. If you haven't got time to watch it today, then you can watch that tomorrow, and it is a recorded session. So also I've just got Shane helping me with some questions and answers in the background. And without further ado, I'd like to introduce our very own Anthony, who's Associate Professor Anthony Linton. And Anthony's our Research Director here at ADRI. And he's also a medical oncologist with many years of experience and a real passion in this field. Today we're going to be talking about treatments for patients with mesothelioma. And without further ado, I'll hand over to you, Anthony.
Great, thank you, Jenny. So welcome everybody to the very first of our Meso Hours. And as Jenny mentioned, I'm a medical oncologist as well as being the academic and research director here at ADRI. And today I want to take you through a little bit of a tour about mesothelioma, and really most appropriately answering many of the questions that patients might have about if you get this diagnosis, what's the right pathway, how to treat this illness. It's going to be going through a little bit of the options about surgery, radiotherapy, but really focusing mostly on the role of systemic therapy, infusional therapies for mesothelioma, and very happy to take some questions at the end. So asbestos has its deadly reputation for a reason and is associated with quite a number of diseases affecting the lungs, but also other parts of the body. And this varies quite widely from what are considered relatively benign conditions, but of which can still be symptomatic, like pleural plaques, airways and lung diseases like asbestosis. Lung cancer can also be associated with asbestos use. But the one that people really think about when they think about asbestos is mesothelioma. And you can see in the picture on the right of really what pleural mesothelioma looks like. So what's the pleura? Well, our lungs, everyone knows about. The pleura is actually a sac that hangs around the lungs and moves with it as it expands and contracts. Mesothelioma isn't a traditional lung cancer. It's not a spot that just starts in the middle of the lung and continues to grow, but rather it actually involves this lining of the lung itself and can really spread quite insidiously, spreading up through that lining. And you can see in the picture of the right there, the way it actually isn't just one localized spot, but it moves across that, effectively suffocating the lung, stopping it being able to expand and contract effectively, and often filling with fluid as well too. Now, mesothelioma can affect other parts of the body, and one of the ones that people have often heard of is peritoneal mesothelioma, which is around the lining of the abdomen. But we'll be focusing mostly on pleural mesothelioma today. So even within pleural mesothelioma, there are a few different types, and you may have heard your oncologists or clinical team talking about some of these. The most common one is epithelioid mesothelioma, and this is really what these cells look like under a microscope. But it can go on a spectrum from epithelioid through to what we call sarcomatoid mesothelioma. And there's a third group called biphasic that kind of sits in between. The bi implies that it's got some epithelioid and it's got some sarcomatoid disease there. Now, mesothelioma is typically diagnosed about 50 years after asbestos exposure, and the implications of these kind of subtypes of mesothelioma are really important because they do have implications not only of the prognosis of the cancer, but also the best way to treat it. Because as we move from the epithelioid to the sarcomatoid, the prognosis can get worse and our ability to respond to chemotherapy can get worse as well. So what happens when someone presents with mesothelioma? Well, as you can see, there's a variety of symptoms that will occur that will often see the patient present to their general practitioner or sometimes even to the emergency department. Over half of patients will experience some shortness of breath or some pain, but as with many cancers, it can also lead to tiredness, some weight loss. And all of those four symptoms can really be associated with many, many health problems. And so it's very common for patients not to realize what's going on straight from the outset, and even for doctors and clinical teams to struggle to organize to diagnose right from the outset. One of the very common things that happens in mesothelioma, in fact occurs in about 95% of patients, is that fluid will build up within their lung, and that's what we call a pleural effusion. Metastases can happen. It can go to elsewhere in the body, but they're pretty uncommon compared to what we see in lung cancer, breast cancer, bowel cancer, and so forth. Now, the diagnosis, as mentioned, can be really challenging because of these non-specific symptoms, and they can often introduce fairly significant delays in starting the right treatment. Now, an X-ray is often one of the first signs that people will see, and that may just reveal the effusion itself. See that fluid build up within the lung. And to really be clear on what's happening, you need to go forward and have a CT scan or a PET scan, which will demonstrate this thickening of the pleura. But that's not enough. What we want to be able to do is actually collect some tissue. And how can we do that? Well, we could just stick a needle in and drain that fluid, and the fluid will often contain cancer cells, but do sometimes find themselves to be a bit non-specific. So ideally, we would like to get a biopsy. And the best way to do that biopsy is what we call VATS, or video-assisted thoracoscopic surgery. And ultimately what that means is putting a camera inside a small cup within the chest, visualizing from the inside, taking some of that fluid out, and then trying to make the lung stick to this pleura so that the fluid won't reaccumulate. Patients will then often see their local doctor, respiratory physician, cardiothoracic surgeon before they come and see a medical oncologist. And all of these people involved in the care may be subspecialized in metropolitan areas and really have a keen interest in mesothelioma, but are often seen by general oncologists and general surgeons in rural clinics. So what are the pillars of therapy once you have a diagnosis of mesothelioma? Well, as with many cancers, it's surgery, it's radiotherapy, it's supportive care. And then we think about the systemic therapies, the therapies that can go wherever the cancer may be, and we do that through the blood. That could involve chemotherapy, but it also will nowadays involve novel therapies like immunotherapy. Really importantly, a multidisciplinary approach is essential. We want to have everyone in the same room, virtually or real, to be able to discuss this case. So that is the respiratory doctors, the surgeons, the oncologists, as well as the general practitioners, nurses, and allied health support staff. And that way we can get the best outcomes for patients. And how do we choose what the right treatment is? Well, there's lots of factors. As I said, because there is often a long gap from exposure to asbestos to developing mesothelioma, many of our patients diagnosed are older. They may be 70 or 80 at the time of diagnosis, and that will impact on what kind of treatments they may be suitable for, because they may have other health issues there as well too. We want to know what their performance status is, how fit they are going in. We want to know about the symptoms at diagnosis, and really importantly, what the patient wants to do. They want to have surgery. Do they want to have chemotherapy? Do they want to have immunotherapy? And this is not a one-size-fits-all approach. As I said, most of the patients are elderly, but we know there are mesothelioma cases from patients as sometimes as young as in their teens, so that's quite unusual. So we've got to be able to look at all these factors together to decide what the best approach. And then we have to look at the disease factors as well too. What is the histology like? What kind of cells are associated with this disease? How far is the disease invaded? Has it gone into the local lymph node or indeed beyond the chest? And how quickly is this all happening? So let's start with surgery. And people often like the idea of surgery because they think about breast cancer and bowel cancer and so forth. Well, let's chop this out, get rid of it, and so it will never come back. But unfortunately, surgery often holds fairly limited value in improving survival for mesothelioma. But it's a really great way to diagnose. That's procedure, that getting the camera in to have a look between the lung and the lining of the lung is often really essential. It's also really important to be able to offer relief of symptoms, shortness of breath, tiredness, fatigue, and chest pain. Now, we can do a thoracoscopy or a pleuroscopy, and that's the camera. It gives us a direct view of what's going on and really importantly gives us access to tissue for diagnosis. But also importantly is the draining of the effusion. Now, sometimes this might just be a single drainage. They put a needle in through the skin, drain 1 litre or 2 litres out and have the patient feeling a whole lot better. But it will often come back. So that's where the VATS pleurodesis is important, which basically is where we put talc in between the lung and the lining of the lung, causing them to stick together so that that fluid can't recur. Now, if the lung doesn't reinflate, the pleurodesis won't work, and sometimes we need to just put in a permanent catheter, a permanent port under the skin, so that nurses can come and drain that fluid out of the lungs once a fortnight, once a week, 3 times a week, to whatever the patient will need. Surgeons might also recommend to do a pleurectomy and decortication where visible tumour around the lining of the lung is actually resected, is removed. And sometimes this can be a really big procedure or it can be a small procedure. It can help debulk and release any trapped lung that is there. And it can, of course, relieve local symptoms such as pain and shortness of breath. People often wonder, well, is there a cure for mesothelioma? And often there was hope felt in the idea of what we call an extrapleural pneumonectomy, which, as you see on the picture on the right, looks pretty intensive. It's taking out the lung, the lining of the lung, the lining of the heart, the diaphragm, and the lymph nodes, really cleaving out anything that the mesothelioma could have spread to. And it absolutely is not for everyone. In fact, only about 5% of patients with mesothelioma are considered potentially suitable for this. And you don't just do it on its own. You do it in the context of what we call trimodality therapy. That is some chemotherapy before the surgery for about 9 weeks, the big operation, and then some radiotherapy afterwards. And it is admittedly a pretty controversial choice. Patients are selected based on their age, their other health issues, what the tissue looks like. We would do this for epithelial or biphasic, but we wouldn't do it for the sarcomatoids. You have to be very fit going in. You would want to know if it's early stage. And importantly, did they respond to the chemotherapy that they had up front? And the reason why this procedure is problematic, and there is this big EPP, but there's also a smaller one called an extended pleurectomy and decortication, where you still remove all the pleura and the diaphragm and so forth, but you keep the lung. The reason this is so challenging is because these are aggressive. There is significant risk of morbidity and mortality, meaning you'll feel unwell afterwards, or you may die during the procedure. And in fact, studies that have been randomized to compare these procedures to not having them have not confirmed a benefit from these procedures in terms of cure or long-term survival, and perhaps even a detriment. So any thoughts about these have to be discussed really carefully with your oncologist and your surgeon. So what about radiotherapy? Well, as I mentioned, after radical surgery, you can give some radiotherapy for about 6 to 8 weeks. Its benefit is also controversial, just as the surgery is. But for palliative reasons, symptom control, or what we call seeding, where it grows along the sites of biopsy, radiotherapy can offer real benefit for these patients. So, for a long time, chemotherapy, however, was the gold standard of treatment. And it's important to note that traditionally mesothelioma was felt to be relatively resistant to chemotherapy, and a variety of single drug chemotherapies really hadn't shown all that much benefit. Back in around 2003, much of our thoughts changed around this, which was the first study that showed that a combination of 2 chemotherapy drugs was really beneficial. Now, for those of you who haven't worked in clinical care before or haven't seen a survival curve, this is a survival curve. It's a curve that shows us what happens as time goes forward, and it tracks how the patients in these studies survive over time. And ultimately, what you want to see is a separation between the 2 curves. So the top curve there is for 2 chemo drugs. The bottom curve is 1 chemo drug, and you can fit a space between them. And that means that the patients who had the 2 chemotherapy drug, on average, live longer than those who had 1. So because of that, we saw about a 3 to 4 month improvement in survival if you had 2 drugs, and so that became the standard of care. So those 2 drugs were cisplatin and pemetrexed, and importantly, it didn't just improve survival, it actually also improved quality of life for these patients as well too. But cisplatin, if you've ever had it or known someone who had it, can be tough. There are a number of side effects, hearing issues, kidney damage, vomiting. And so cisplatin has a cousin drug, a drug called carboplatin, and it's a pretty reasonable alternative, and it's just about as effective. So for many, many patients we treat, in fact, I'll say the majority of patients we treat, we end up giving carboplatin instead because you tolerate it a bit better and your fitness is a bit better as well too. And it doesn't cause the hearing issues, the kidney issues, and the severe vomiting. Now, we did that for a long time. So in 2003, this study came out that showed the two drugs, and then it was all fairly quiet in the space of mesothelioma new agents until we started looking at a drug called bevacizumab. Now, bevacizumab is an antibody that inhibits the development of blood supply for tumours. And all tumours, just like everything else, needs blood supply to continue to thrive and grow. And we already knew that it was an effective agent in colon cancer and ovarian cancer. In fact, in metastatic colon cancer, it's one of the standards of care of treatment. So based upon this evidence in other tumours, they tried it in mesothelioma. What they did for this study, it was a randomized study that compared people receiving the traditional chemotherapy of cisplatin and pemetrexed to putting it in, cisplatin, pemetrexed, as well as this drug called bevacizumab. Now, you had to be pretty fit going in, and you had to not have had chemotherapy before. And once you had the bevacizumab in combination with the chemotherapy, you were allowed to keep going on with the bevacizumab on its own. So what did it show? Well, we've got the two curves again, and we can see a gap between them once again, which means that there's a difference. So what we could see that those patients who received the bevacizumab lived about 2.5 to 3 months longer on average than those who had the chemotherapy on its own. So once again, a new standard of care for treatment was to look at giving these drugs as combinations together for those who could tolerate it. Now, bevacizumab, as with any drug, does have some side effects, but it's generally tolerated pretty well. People do sometimes worry about some blood pressure, some protein in the urine, and some rare risk of some issues with the bowels. But for the most part, people feel pretty good, and it doesn't feel that much worse than chemotherapy itself. But then what happens when that stops working? When that stops working, we start thinking about second-line therapy. And to be fair, in all of the trials, there was very, very limited evidence to tell you that one drug over another was all that great. We had drugs like vinorelbine, combinations of gemcitabine and epirubicin, even 3 drug combinations, and they were all just about as good as each other. And there was no clear or recommended option. Sometimes if it had been a while since the first lot of therapy, if we'd hit 12 months, actually the best thing to do was to retreat with the carboplatin or cisplatin and pemetrexed again. But if it had progressed faster than that, we were in trouble and we needed other options. Then immunotherapy came along, and it's been considered the next big thing for a lot of cancers for about a decade now. If you ever watch A Current Affair, read a newspaper, you will see every second day a new cancer cure, a new thing that has changed everything. And the cynic in us says that, well, that sounds great, but actually doesn't make a difference to patients' lives, because often the next cure was just some cells under a microscope or some rats in an animal house, and not something that made a significant difference to patient lives. Immunotherapy was really different. So this is how immunotherapy works. And even as an oncologist of many years, this is all pretty complicated. Looking at how the way APCs and T cells and so forth get into tumors and interact and engage and kill cancer cells. And that is enough to send anyone crazy trying to figure it out. So we make a nice cartoon instead. And this is a cartoon I teach to registrars and junior doctors as well too, to explain it best. And I actually think it's the best explanation of immunotherapy I've seen. In short, we've all got T cells. They are what help fight infections in the body. And those T cells, those white cells, also recognize and target cancer cells. The trick is that cancer cells learn to fight back. So they use something called PD-1, which they have, to target something called PD-1 on the T cells, knocks it out, make the T cells not work, and allows the cancer to escape and the cancers to set up home and grow. PD-1 inhibitors are a new class of drugs that basically act to release the brakes, let the immune system do what it's meant to do. Consider it a helmet for T cells. The PD-L1 tries to attach, it can't because it can't interact with the PD-1, so the T cells are able to do what they need to do, they can function, they can fight the cancer. So many of you will have heard about immune boosters, and many patients will come and say, well, what can I do to boost my immune system? And usually it involves some combination of ginger or vitamin C or echinacea or otherwise. Immunotherapy is real immune boosting. It is letting your immune system do what it's meant to do, but the cancer hasn't until this point let it do. So a very large study came out a few years ago called Checkmate 743, and it looked at a combination of two immunotherapy drugs, one called nivolumab and one called ipilimumab, and it was given in the first line and compared to standard chemotherapy. Once again, we have a new survival curve, and once again, we see a nice gap between these two lines. What we could see was that the average survival for someone with mesothelioma increased from 14 months to 18 months, a 4-month difference. And as you look out to 2 years, what that actually meant was that instead of just standard chemotherapy, where about a quarter of patients would still be alive, 40% would still be alive if they had immunotherapy. But really interesting was when we then broke it down by the kind of cells you have. So most people have epithelioid disease. They still had an advantage, about a month and a half advantage from having immunotherapy. But in fairness, that group also did better with chemotherapy. It wasn't statistically significant, which means that we can't be 100% sure that it is better than chemotherapy, but ultimately we can see that both of these drugs, if you had epithelioid mesothelioma, you could have immunotherapy, you could have chemotherapy, and in both cases you do pretty well. But the real difference was in the non-epithelioid disease, the biphasics and sarcomatosis. For this group, mesothelioma was a quick death sentence. With chemotherapy on their own, the average survival was less than 9 months. When we gave this group immunotherapy with the 2 immunotherapy drugs, that doubled. Effectively, the non-epithelioids became like the epithelioid, and it was the first thing that we'd ever shown made a real difference in non-epithelioid disease. So immunotherapy became the standard of care effectively overnight. Now, because it turns on your immune system, immunotherapy has side effects. Anyone who has eczema, rheumatoid arthritis, lupus, inflammatory bowel disease, all of these people have an immune-related condition, and immunotherapy can recreate those conditions. For your endocrine, your hormone system, your thyroid can play up, become too powerful and then less powerful. In your lungs, you may get inflammation of the lungs. In the bowels, you may have inflammation of the bowels, or the liver, or the pancreas. The liver, the kidney can become inflamed, the joints can become inflamed, the nerves can become inflamed, the skin can become inflamed, causing a rash. Pick any part of the body and it can become inflamed. And when a patient will look at all of those side effects together, it sounds absolutely terrifying. Now, the trick is no one gets all of these things. Most people will just get 1 or perhaps 2 of those side effects. And when they broke down how the side effects affected patients, what we actually saw for most people was the issues were going to be relatively mild rash, relatively mild diarrhea, thyroids. They were the most common things that we saw. And when we talk about the grade, how severe it was, grade 1 and 2 being quite mild, grade 3 and 4 being serious, meaning we need to stop the therapy, may need to come into hospital, put you at risk of dying. Only very small percentages of these patients experience those side effects. We've also become really good at how to treat these now. And how do we treat it? Well, we withhold the steroids and we withhold the therapy and we give steroids, either as an inpatient or outpatient. And that often does a fantastic job at reversing things. It can get really dangerous. People have died from immunotherapy. But by far and away, those who get the bad toxicities often respond well to steroids and get home again. And in some cases, we may be able to reintroduce the therapy again, either as a combination or a single agent. Now, because we know the immune system will flare, there are people who we don't think should be suitable for it. If you've got terrible rheumatoid arthritis, terrible lupus, terrible inflammatory bowel disease, we often won't recommend you have immunotherapy because there's a very high chance that they will flare when this happens. But it's not an absolute decision, and the decision to treat would be made in combination between the oncologist, your other specialists, and also yourself. Decision to treat made depending on the severity of disease and how well controlled it currently is. If someone is already needing to be on very high doses of steroids, we often don't put them on immunotherapy because we think that the steroids won't make them work quite as well. The good news is if you are unlucky enough to have bad toxicity, what we see in many cancers is actually if you have bad toxicity, survive and need to stop the drug, actually often those patients do better than those patients who never had toxicity and never needed to stop. And that's really just a sign of a primed immune system. And often the responses can be durable. They can last for many months or in some cases many years afterwards. It also means, though, that the side effects can sometimes come on after you have finished the therapy. So if chemo works and immunotherapy works, can we combine them? Can we put the two of them together? Well, studies have done just that. This was a study that once again looked at chemotherapy, but it looked at chemotherapy in combination with another immunotherapy drug called pembrolizumab. We look at the two curves together. Once more, we see a separation of these curves. People who had combination did better, but perhaps it wasn't quite as impressive this time. Just over a month's improvement. So we then broke it down once again. We said, well, how did the epithelioids do? How did the non-epithelioids do? Well, for the epithelioids, didn't really make any difference. A subtle improvement in survival, but most people actually did well anyway, not statistically significant. For those who had the non-epithelioid disease, once again, we saw that the addition of immunotherapy improved survival significantly, improved from an average survival of 8 months to 12.5 months. But if you remember, it's not quite as good as when we had the two immunotherapy drugs together. So this did not become the standard of care. We still like to give the ipilimumab and the nivolumab together. It's important to note that there are other treatment considerations to make, and that is where symptom burden and palliative care come in. Early palliative care referral for patients who have mesothelioma is really important overall. They can be involved in pain relief. That could be with opioid drugs, things like endone, Targen, OxyContin, paracetamol, or neuropathic agents that target particular nerve pain. Improvements with breathing is often needed, whether that be supplying home oxygen or using these opioids again to help ease the breathing. Nausea and bowels often require supportive medications as well too. Weight loss, as with many cancers, is a really common symptom, and so dietitian involvement to help with the diet, to get on some protein supplementation can be really helpful. Physiotherapy and an exercise physiologist can be really important, as exercise is essential to be able to maintain that good performance status, which means you'll tolerate therapy okay. Occupational therapy can also be really important, as the patient may experience some functional decline, which means they might not be able to do things at home as well as they normally would and need support with that, either by equipment being brought in or some assisting aids at home. A social worker will be able to help you navigate the other support that may be available, and psycho-oncology support. Any diagnosis of cancer can be psychologically devastating, particularly one that is associated with a disease and exposure to something like asbestos, which was out of the control of the normal person and was as a result of a workplace disaster. So that psychological support is essential not only for the patients, but also for their families. So really important then is to look at, well, what comes next. So in 2026, what I do at the moment is I give them immunotherapy up front most of the time, and then I give them some chemotherapy and bevacizumab after the fact. Sometimes I'll give the chemo first and the immunotherapy second, particularly in epithelioid disease, but you could go either way. One of the things that we haven't talked about is obviously what we do if the cancer is really slow growing, and sometimes mesothelioma will do that. There may be some fluid. We might deal with the fluid. We may know from a biopsy or that fluid that the cancer is there, but we don't necessarily need to rush into treatment because the cancer might be slow. In fact, on some earlier work we did with the Diseases Board in the pre-immunotherapy era, we knew of the patients who survived up to at least 2 years. Only about 40% of them got chemotherapy. So there were many patients who just had slow-growing tumours that didn't bother them too much by doing nothing at all. So it will not be uncommon for your oncologist to say, let's see what the bulk is and let's watch this space. And maybe we'll repeat a scan in 2 or 3 months. And if things haven't changed that much, continue to watch. But we want new things. And that's where ADRI and other labs around the world come in. And so I'm going to show you a couple of things that we've worked on with our researchers here that we think have provided some exciting opportunities, as well as some of the research we're doing going forward. I talked about PD-1 and CTLA-4. That's the nivolumab and the ipilimumab. And we see in these mouse pictures here a group of mice who have mesothelioma and what happens when we treat them in a lab. If we do nothing in the top bar, the control, the cancer continues to grow. If we give chemo, some respond, a lot don't. Even with immunotherapy, we get some good responses, but not complete. So TIGIT's another target we looked at, and so we combined it with an immunotherapy drug. And a really important paper published by Peter Shih, one of our postdocs, revealed that this combination in mice model actually led to a cure, a complete removal of the mesothelioma in all of the mice involved. Now, mice are mice, they are not human, and 5 mice is not enough evidence to say this becomes the standard of care for the rest of us. But it does provide an early clue that we then look to take on into human trials so that we can see whether this has legs, whether it can make a difference and help patients. Similarly, we also know now that the gut microbiota can also potentially influence treatment response as well too. Now, the microbiome is something that many of you may have heard about, and it's basically the bugs that are within your bacteria. And these are normal. We all have them. We've got millions of bugs within our gut, and they act like a fingerprint, if you will, and they change within individuals and within communities. We know they help with digestion and metabolism and immune functions and so forth. And we found in some early work, again led by Peter Shih, that mice who responded to immunotherapy had quite a different set of gut bacteria than those who didn't respond to immunotherapy. So one of our projects that Peter's leading at the moment that is funded by some of our supporters is to look and see in patients how this makes a difference. Collect samples from patients of blood and stool as they go throughout their therapy, and to determine whether or not we similarly see that variation in humans between those who respond and those who don't respond. Because if we can identify these differences, well, then perhaps we might be able to change it. Maybe we might be able to give a supplement, a probiotic. Maybe we may be able to do a fecal microbiome transplant, which involves giving some of that bacteria to patients with immunotherapy and seeing whether that may help. All of that really, highlights the importance of research and studies. And one of my colleagues, Professor Stephen Cow, will be giving a talk in a later session over the next few months, talking about clinical trials. But we rely very much on the support of patients and their families to run these, because through these trials, both in the laboratory and also in clinical studies, we can find the next big thing that can help. We have a ADRI biobank, a storage system where we collect samples of blood, stool, tissue from patients with mesothelioma, and we use those samples that have been so generously provided to be able to look at some of these studies and see whether or not we can find new markers to diagnose, new ways to treat, new ways to improve current treatment. So if any on the call are interested in being involved with that, they should certainly reach out to ADRI, and we can tell you whether your local oncology centre is involved or whether you'd be able to donate in person here at ADRI. I'll take this opportunity now to thank you for listening, and very happy now to take some questions.
Thanks, Anthony. That was a wonderful presentation. Thanks for your time today. And I'd just like to open it up to the floor now for questions. If you can raise your hand at the top of the Teams, you'll see the raise hand. And then I know that you've got a question, and I can unmute you. There's no questions in the chat.
No, Jenny, there's
And
nothing's come through as yet.
Thanks. And don't be shy to ask questions if you've got one. And if there's no questions, I'll ask a question, Anthony. Oh, hang on.
We've got one question.
Hi there. My name is Simon. Thanks for the presentation. I've actually had the EPP almost 4 years ago. In fact, more than almost 5 years ago. I'm doing pretty well. And I'm part of a support group of similar people who've had the same operation. And I'm probably one of the newest to join that group. It's people there, 7, 8, 10 years, even more. So I'm wondering why doctors aren't more supportive of people having the EPP.
So it's really tricky, Simon. That's a really good question, and I was anticipating someone to ask, because I also have patients who have had EPPs and they're doing well and they have been alive for many years. Clinicians and scientists like hard evidence data. They like randomized data to be able to prove. Because what the cynic will say is that the reason the person who has an EPP does so well is because they were really carefully selected at the start. They chose the fittest patients with the best pathology and the smallest bulk of disease. And they may say, if we did nothing, maybe their disease would have progressed slowly anyway. Now, that's tough to say. And the flip side of the coin is the surgeons who will look at some of the studies that said that EPP didn't work will say, well, you chose the wrong surgeons, not the wrong patients. So there was, for example, in the study that said that EPP wasn't helpful, there were pretty high morbidity and mortality rates. And a surgeon like Brian McCorn, who used to do a lot of them at RPA and Lifehouse, will turn around and say, those findings are rubbish. My morbidity and mortality rate is much, much lower than that. And that's fair. Brian is an absolute expert in that field. So that's why it becomes a discussion. And it's got to go in sensibly. The EPP data that said it didn't work well was not as strong as the extrapleural, the extended pleurectomy and decortication. That was a big study. That was pretty much lights out. It proved that those patients did not live as long. EPP is tricky, but there will always be this doubt of whether or not really that was done because you chose the patient so carefully, or they were just lucky enough to have such a small bulk disease, or it was never going to grow that fast anyway. So there isn't a good answer, Simon, but it's why we have discussions and why we have MDTs to go through that.
Okay, thanks.
Any other questions?
We have a question.
Mark Wallace.
Oh, lovely. Yeah. Yep, go, Mike.
Hi, yeah, thanks, Anthony and Jenny. I'm just interested in the gut microbiome. I know you said there's no direct evidence yet, but is there any harm in trying to increase your gut flora,
Yeah, it's really tricky because I think the uncertainty at the moment is which bacteria are actually involved in producing the good outcome. Because we have millions of gut, it's hard to know. We have such widespread dietary variability in the community anyway, between different patients, different cultures, different ways of living your life. So we don't quite know the answer, which is why the research is really important. I think there's many who will say things like having a high fiber diet probably will hold some value. And, if I had cancer at the moment, I'd probably be trying to be good and have a high fiber diet. The oncologist in me would always say, well, I also want to make sure that your weight maintains steady, so you should have protein as well too. But should you be taking a supplement of Eat a Health Plus or probiotic at the moment? I don't know that we know the answer to that yet, which is why we're trying to look at that at the moment. And it's part of a raft of studies that we'll be doing over the coming years, looking at what bacteria makes things respond and what doesn't, what diets make people respond and what doesn't, whether or not probiotic, whether or not other dietary changes can make a difference. So it'll be interesting to see, but I think we are still in an evidence-free zone.
Okay, thank you.
Thanks, Mark. And Greg has a question, Anthony. If you can just unmute yourself, Greg.
Hello. Let's do.
Greg, we can hear you.
We can hear you.
Dr.
Just
Linton.
ask your question.
Thank you. I also had an EPP about 6 years ago. I was just curious with the lining of the heart. I heard that lung and everything else is sort of removed just around it, but does the heart lining also get removed?
So it can do, Greg. It certainly can. The extent to which they take all of this will vary from procedure to procedure and depend on the position that the bulk of the mesothelioma was at the time. Yes, they do try and take some of the pericardium. They don't always take all of the, well, sorry, they certainly don't take all of the pericardium, but they may take components of it.
Okay. All right, thank you.
And Elizabeth, you're next. You've got your hand raised. If you want to ask your question, just unmute yourself.
Yes,
Sorry.
my daughter's with me.
Yeah, sorry, it's Lisa here. So I'm sitting with my mum, Elizabeth, just now. So she didn't want to ask the question, but I'm asking it
Hi,
for
Lisa.
her. So, hi. So my mum had, obviously she was diagnosed last year, February last year. She started immunotherapy April last year. Now, she could only be on it for about 4 months before she had severe colitis and acute kidney injury, which rendered her in ICU. So she almost died from immunotherapy. Now, she's been going for regular checkups every couple of months. She's had no growth in the last 12 months, which is amazing. I know you mentioned earlier that when people have adverse reactions like that, it's because their immune system is primed. Is that correct? So
Yeah,
obviously
that's
her
right.
having that reaction
Yeah,
would
that's
be a
right.
good thing.
So it's not always definitive. So of course you can have some patients who have terrible reactions and still their cancer grows. But equally, in fact, more likely you have these patients who it becomes primed and they have these durable responses. The exact data in mesothelioma says that in mesothelioma, we don't have that evidence yet that says absolutely you get bad toxicity in meso, you live longer than those who didn't have bad toxicity. But we extrapolate from other tumours as well where that data is seen, tumours that are certainly much more common from mesothelioma and generate that data earlier. And certainly I look at patients in my cohort, both of mesothelioma and lung cancer. I've got patients who had 3 or 4 cycles of immunotherapy for a small cell lung cancer, had bad liver toxicity, had to stop, and we are almost 5 years after, and their cancer has never grown back. And that's of a small cell lung cancer where, if you think mesothelioma survival rates are bad, small cells just as bad, if not worse. And we can see a similar thing of how immunotherapy has changed the game. So yes, I think that's reassuring, your response today, Lisa. We don't know when that changes, but certainly does explain what Mum's experience so far has been today.
All right, but we're taking it as a win at the moment that she has had no growth. So
yep, take
yeah,
it as a win. Definitely a win.
Yeah. So yeah, her oncologist is really like, what did she say yesterday, Mum? It's looking very promising, in terms of no growth. She's done regular CTs and PET scan the other day. So we're just hoping that it continues like that, and that 3 or 4 months that she had of immunotherapy is enough to
absolutely, yeah,
keep her going for a very long time.
Thank you.
Following on from that, Anthony, there's a question in the chat. Is there any data on the incidence of serious side effects from immunotherapy, such as severe colitis, neuromuscular symptoms, or cardiac symptoms?
Yeah, they're absolutely. So any of those numbers any of those side effects can occur. What we usually see, and I'll flick back to the earlier slide that kind of gave a bit of a pictorial representation of that. So here's what we saw for the EP-NEVA, which is the standard one that we see here. So grade 3 and 4 toxicity usually means that you've had to come into hospital or you've been pretty unwell. So we can see for skin, for example, that's the one where it's most common. 30% of patients who have EP-NEVA will have a skin complaint. 3% of those will have severe enough to need to come into hospital, need to stop therapy, need to go on some steroids and so forth. Gastrointestinal, we're talking about 5%. Endocrine, 1%. Hepatitis kind of pictures about 5%. Pulmonary about 1%. Renal about 1%. Generally, we think that any of these individual things, it might be anywhere between 0.5%, 1%, 2% for most of those rarer side effects. Now, of course, you're going to add them all up together and say a risk of a bad grade 3 or grade 4 toxicity may sit more in the realm of 30% or 40%, but that doesn't necessarily mean that everyone is having terrible hospital-ridden side effects. Sometimes a grade 3 toxicity is recognised on a blood test, or you don't feel that symptomatically unwell, or you can avoid hospital as well too. But it's certainly real. It certainly prompts discussion. You've still got to be pretty fit, able to handle it in the first place.
Thanks, Anthony. I can just see another question as well that Viv has in the chat, and I actually really like this question. So it's what are the main questions someone should ask their oncologist when they first receive meso diagnosis?
Okay. So I think that first is the basics of how far has this spread? How quickly has this been happening, and how fast is it growing now? Now, your oncologist may not always be able to answer that question straight away. A CT scan is one point in time. And it may be that you don't know the speed of growth until the next scan 3 months after. Now, if you're really symptomatic, your oncologist by and large will say to go on to treatment straight away. If you're asymptomatic, if this has been an incidental finding, sometimes you want to have that 3 months to be able to tell what the speed of growth is and whether or not you need to jump into treatment straight away. The next question is going to be, what treatment do you think is best? Now, as I said, it's very clear. If you have non-epithelioid disease, immunotherapy is the path forward. For the epithelioid, however, chemo and immunotherapy are about equal with each other. Now, what I will say is almost every oncologist in Sydney gives immunotherapy preferentially. The data, non-statistically significant, supports that. But really, you can go, in honesty, you can go either way. But I think for many of us, find immunotherapy perhaps a little bit better tolerated. I certainly give immunotherapy first up to patients who don't have an obvious reason that I can't give that. But I also think there is an element that all of us, there's always fatalism that comes in with a cancer diagnosis, and it can go either way. Sometimes there are medical professionals that are fatalistic, particularly those who don't treat mesothelioma or see otherwise and think, well, treatment's not going to work. Meso never had a good outcome, so I don't do anything. The flip side is people who go in with a lot of false hope and think we're going to fix everything. I think at heart, as a child of people who have had cancer, but also as a person who talks about cancer all the time with my own patients, I just ask my oncologist to be honest and fair. Talk through what you think is reasonable. Talk through what they would do if they were in your situation. Talk honestly about what the likelihood of success is, what the likelihood of failure, what the impact on your quality of life is going to be. And then think about what works for you and your family going forward. The absence of a cure is something that's really important to discuss. I think the idea that we go into these things expecting miracles can be really tough because the evidence doesn't bear that out. But we all have patients who have done exceptionally well. And if you can tolerate treatment, and if your life can tolerate it, and your quality of life can tolerate it, you know, being 80, being 82, 83 is not a barrier to having therapy. You just got to make sure that we're fit enough to handle it and that your family will be okay.
Great, thank you. I can't see any other questions in the chat. Does anybody else have any questions? I just have something, Anthony, that I think you've sort of touched on already, but I was just going to ask about where you think treatment options are going in the next few years, although I feel like you've sort of touched on this.
So immunotherapy has been the big change. There's no doubt about that. Do I think that immunotherapy combination treatments with immunotherapy and chemo combinations are the way of the future? No, I don't think they're going to be, not in the current iteration. I think that there will be new things. There will be better versions of immunotherapy that come out. There will also be things that we combine with immunotherapy. There is antigen or antibody-directed therapy, ADCs, that are out at the moment. They are the next big thing. We see some promising result. We haven't really looked yet at the idea of immunotherapy combined with blood supply kind of targeting treatments, and there are studies that are going on at the moment, not just in mesothelioma, but more general studies. So I think there's a lot of areas that things are going to change. I think our ability to take a deep dive into the genetics of the tumours will also improve. And I do think the microbiome will help in some way, perhaps help select patients, and potentially solve some of those riddles we don't know the answer to yet. When we say that immunotherapy and chemo are as effective as each other, well, maybe a marker in the blood or maybe a marker in your gut microbiome will help tell us, well, you should be on chemo and Fred should be on immunotherapy. And we know this because of, you know, a particular marker that we have.
Good, thank you. Thanks so much. Anybody else? Go on, Mark.
Sorry, yeah, Joe, just one last question. Just out of curiosity, how long has the ipilimumab and nivolumab treatment been being used? How long approximately?
Yeah, so Concord, which is the oncology practice I work at, we were doing the study back, I think the study, did it start in 2018, 2019, something like that? The data got published, if memory serves, at the end of 2021, I think, was when the data got published. So it's been about 4.5 years ago now from when that data came out. So it's been, that data came out, I think it was in an August or September. The access program was opened within 4 weeks. It went on the PBS about 9 months later. So it was on the PBS, I think, for 2022, but patients could access it from the end of 2021.
Okay, thank you.
Okay, thanks, Anthony. That was a wonderful session. I really appreciate your time today. I'm sure that everybody online will appreciate your time and the knowledge that we've learned today. I've certainly learned something new, as I always do when I talk to you. So with that, thanks for everybody for attending today. I really appreciate everybody's time, and it's been a really good first session. And just to say again that the recording will be online by tomorrow on our website. And also on our website tomorrow, you can also apply to see Amy. So Amy O'Donnell is going to be our next speaker, and that will be the 3rd of March. So she'll be speaking on the Tuesday at the same time. So Amy is a specialist nurse lung cancer at the Chris O'Brien. And so I'm really looking forward to welcoming Amy for that session. And so please, I hope that you can join us for that session. And yeah, thanks everybody so much for joining today. And with that, thanks, Anthony.
Thank you.
Thanks,
Bye.
guys.
Thank you.